So, welcome back. We are the way it's working out pretty well. We're going to basically this is all obvious. None of this material has anything to do with the exam on Friday. This is all after. There's basically it's interesting. It's this is a part of the third exam, but it's mostly the immune system, and we'll get done with most of the blood vessel stuff. I would think today and Thursday, and the exam will be on Friday. So that's kind of where we are. So timing wise, it's working out in that regard. Let's see. So I'll try to pick up because I missed this is kind of roughly where we left off. So I'm going to talk about this is where the physiology, the regulation of it, a little bit about how blood gets redistributed. A lot of it, there's a fair amount of information. It's not what I would call quote unquote testable. I hate to say that because everybody's like ears shut off. The reality is, I mean, I want to give you a general view about this because it leads into so many other things. Blood pressure it impacts all the other systems we're going to study, the least of which is the immune system, I would say, that we'll come to. But when we get, this unit is blood pressure and immunology. The final is what I call the systems, the rest of the systems, respiratory, digestive, urinary, reproductive. So the final has a fair amount of content. You should be hearing from me say that. So it impacts all of them. This is sort of the groundwork, if you want to look at it that way. And I think it's a convenient way to look at it. Why it's so important. And these are the controls. The whole idea is if we don't regulate blood pressure, and it's not, again, it's very much of what we call a silent killer. So we really don't know until it's too late and all the factors that are part of it. So we have limited controls that are there. Most of the time, it kind of does it itself. Okay, it's just blood vessel diameter. Okay, and the brain is the perfect example. The brain, as you will see, is all about maintaining flow. I have seen PowerPoints. I've even seen parts where I've read, when we're exercising, we need more blood flow to the brain. We don't. The brain is all about constancy. If it doesn't have enough, effectively think of it, you could faint, conceivably die over the long term. And if it has too much pressure of blood pushing in there, the trouble is it could cause blood vessels to burst, and you could end up with something like a stroke, what we call a cerebral hemorrhage from burst blood vessels. It's one of those not enough and too much things. There's only just right when it comes to the brain. Okay, so effectively, the two most favorite areas, as you can see here, in order, brain and then heart. They continue to receive blood. After that, I would dare say kidney would be third on the list. So if you were looking at from a core perspective, when your blood flow would somebody was injured, I mean, those areas would be in that order protected. And if you ended up losing, let's say, the kidney, now that's you're having a massive bleeding, external or internal. And so it's all about supply and demand, as a lot of things are. And the body's just an example of, Eco 101. If you have to take economics around, a lot of schools used to make you take eco. Don't like it. You took it, hated it. Yeah, I couldn't stand it. Just side note, get into it. It's really important to understand how things work. People who do well in that somehow manage their money. People who don't pay attention to it, not good with money. Me. I married someone who's good. Thank goodness. I have a single approach to money. Spend it. So that's why we're fixing my 2012 Volkswagen as opposed to, engaging ourselves in a new car payment with, let's say, a new one. So I proposed and was shot down. Oh, done. Strikeout. Done. We could use a new car. We are not having another car payment. We're going to be 74 years old. Thank you for pointing that out. That's how the conversation went. I knew how to take yes for an answer. No, yes, we're not doing it. Moving on. So we have different things that control it. So there are different centers. Our heart can either accelerate or inhibit they can sense pressure, and these are called vasomotor. And that's what I mean. The most important measure is that vasomotor tone. That is what the sympathetic, because it's only sympathetic nerves go to blood vessels. Those sympathetic nerves are the ones that establish this almost like a resting pressure in the blood vessels. That's really your blood pressure, more than the top number. Top numbers vary, bottom numbers stay fairly constant. These are one, and these are some we have. These are pressure sensors. Baro means pressure. There are several of them. There are two major. One is at the bifurcation of the carotid arteries. Another one is in the aorta. And indeed, when a lot of people would have high blood flow, and sometimes that contributes, let's say, to migraines and different kinds of headaches, they'll actually teach them how to do carotid massage. That's there to try to, like, maybe, it's almost like you're trying to work those pressure sensors and have them kind of say, okay, I'll take a break now, and it'll limit the blood flow going up to the brain. Since, I do not know if they still use that. There were a lot of different techniques because headaches have always been hard to manage. Today they use a lot of medications. I'm not fond of them, but not for me using them. My first wife had terrible migraine headaches. Just ended up taking too much medicine for it, I thought. Nevertheless, so what happens is that mean arterial pressure, that really important measure that you really need to remember, okay, what it will do is it'll stimulate those pressure receptors and it'll make adjustments. It'll either, if they need to be slowed down, if there's too much pressure or if there's not enough pressure, it'll either accelerate or inhibit. Just depends on the demand. So you can imagine what it would be. Typically, more often than not, when we have long-term disease, there's too much pressure and it has to be able to try to slow things down. When we begin to see it excel, why would it increase? That's when we see something that I have, and anybody who takes blood pressure medicine long-term have, particularly it's called postural or orthostatic hypotension. You will see it later. And this is a very good teaching point for maybe your parents, maybe your grandparents, maybe you have great-grandparents, that type of thing. Is you see that, and what we always teach them is that, particularly it's like if they hear a phone, if they hear an alarm or a noise, don't jump out of bed. Okay, too fast, because those mechanisms weaken over time, and modern blood pressure medicines don't help them. If anything, they quiet them down. So all of a sudden you get dizzy. So you're not getting enough blood flow to your brain. It'll come back. So I did it this morning. I get up, I just sit at that position for a second. Glasses on, double check, make sure I got the time right. I didn't all of a sudden wake myself up and I've got 2 more hours. I don't have to do anything. I'll do that. And the same thing when I stand up. And I'm no different than anybody else. I remember telling my mom was in a walker. Okay, make sure you do. Oh, they told me this. Well, I'm reinforcing it. Because it's common, and that's an easy thing to deal with. That's when we begin to see when you're trying to compensate. Because you're going to see every effort is made to keep the blood flow to your brain constant. Some people erroneously think that like increased exercise or increased activity. No. It's all about constancy. Not enough and too much are both bad, so we want constancy. So what happens, those pressure receptors, okay, 2 mechanisms that will, let's say, lower it when it needs to be. They'll dilate, okay. There'll be the vasomotor, that's sympathetic nerve fibers, that's from autonomic. They'll relax a little bit. They'll vasodilate. The pressure will fall, and even the veins will dilate. So you'll have less venous return in cardiac output. The other thing that they do a lot of is they'll tell your heart to slow down or speed up. Those pressure receptors, a major area of compensation is with your pulse. Major area. Another thing that they used to do with that carotid massage, when people would sense that because, oh my God, my heart's racing, that would slow it down. I do not know if they do that today. These were things that I was learning about those things, 40, 50 years ago. So again, if there's not enough cardiac output, okay, that's there. They slow down the sympathetic activity, stimulate the parasympathetic. Okay. So what you're trying to do is, if you're looking at this, can lead to it, reduce the heart rate, its contractility, the cardiac output decreases, etc. Okay, sometimes they can it can accomplish this if it's desired, or it can do the opposite if it's not. So for instance, if it's low, we get vasoconstriction that increases cardiac output and pressure. Okay, and these are what I was talking about. These reflexes. The sinus is the name of this baroreceptors, and they're all about the brain. And getting it to the rest of your body is called the aortic sinus. So carotid sinus and aortic sinus are the names of the baroreceptors or pressure receptors. If you see in your readings or you hear in another course, they talk about the carotid or the aortic bodies. Those are chemical receptors in the same area. Pressure receptors are probably triggered first. Chemical receptors are second. And so the thing is, if it's excessively high or excessively low, there's adaptations. And unfortunately, the adaptations, particularly for high blood pressure, that's why high blood pressure over time is such a problem. That our ability to adapt to it. I can't emphasize, because you see people who are perfectly healthy otherwise, and just say, oh, I never go to the doctor, I'm always healthy. And that's the hidden high blood pressure. It's so devastating, because the first time they'll find out about it, I've said it already a couple times, I'll have a stroke. Scary. Scary. Moving on. Okay. Here are the chemical receptors. Again, the old days we used to call them the aortic and carotid bodies. Okay. The big player, particularly so when we get to the brain and the impact and the impetus that drives us to breathe, is carbon dioxide levels. People mistakenly think it's oxygen. When we start looking at respiration, we'll look at what they call the oxygen saturation curve. It's a very interesting curve. If oxygen levels are causing your heart to change or you to breathe, you're in big trouble by now. Carbon dioxide is much more sensitive. So carbon dioxide, and what this plays a role in, okay, if there's an increase in carbon dioxide, you might remember we had that thing called a carbonic acid buffer. Water and carbon dioxide in the presence, there's an enzyme in the blood called carbonic anhydrase, which you don't have to know. My advanced students have to know that stuff. And that makes this thing called carbonic acid. Carbonic acid is a weak acid. It's not me. I just checked. So, hey, I do it. Anybody, it's okay. Weak acid. Weak acids make great buffers because they'll give up a proton or not. The thing here is, what happens is, if you have more carbon dioxide, this is chemistry 101 that everybody probably had. If you increase, it's like increase the ingredients, you make more of the end product. If you have more carbon dioxide, you have more carbonic acid, it's still an acid. It's going to release more protons, and that's going to lower your pH. That's bad. So the trigger, if anything, the batting order for what causes these changes, carbon dioxide first, pH, because it's directly related to carbon dioxide second, oxygen last. And it'll signal the acceleratory center, increase cardiac output, vasomotor center to increase the resting tension, etc. That's how it works. When we get to respiration, you're going to see it's very specific, because the cerebrospinal fluid has similar sensors. The thing is, that magical enzyme that allows this to be reversible doesn't exist. So that's why, and I'll tell you this all again when we get to respiration, that's after the immune system. And that's why your big impetus to breathe is carbon. It's like that little kid goes, I'll hold my breath and collapse and you'll be sorry. And the reality is, eventually they're going to get so much carbon dioxide, they're going to have to breathe more. Doesn't work. Can't do it. Physiologically impossible. Okay, so there's lots of other things. Typically in the medulla, you have sensors that control. They make things relatively rhythmic for all of these things to make sure that the blood is distributed appropriately. We don't have to worry about it normally. Okay, If we're being active, it changes from when we're inactive, and it depends on what we're doing. So there's lots of higher centers to particularly they'll adapt during stress. Okay, they'll redistribute it during exercise, and that's really significant. Temperature increases the need, okay, a little bit more so. I mean, so when we see the effects of temperature, it depends. Or we raise, is the temperature being generated as body temperature because we're exercising, or do you have a temperature because of some inflammatory process, like an infection, like a virus, whatever? Then your response is different with regard to it. Okay, theoretically, it's you understand that that kind of temperature raise is good up to a certain point. And we get to this in the immune system because inflammation is a normal process. We want it to occur. We want it to accomplish a task and then disappear. Okay, when it doesn't, now we have a problem. We'll get there. So lots of different things. Epinephrine and norepinephrine are the principal hormones from the adrenal gland. They are short-term controls. We don't want to use them all the time. We talked about, didn't we cover the renin, angiotensin, aldosterone mechanism, right? Okay, same deal. That these are short-term controls. They're fine-tuning it. Okay, I'm getting up, I'm going to be a little bit more active. All of a sudden, you're going to get a certain amount from this, particularly if you're doing a sustained activity for, it's like mini fight or flight. I'm going to, I forgot that in my room. I got to run over there and get and race back to class. Epinephrine and norepinephrine. Again, some of the controls we don't even have to think about, and that's that renin angiotensin mechanism. What happens? Eventually we get to this. What does it do? So you should know all of these points. What does it do when we finally activate that? And all that's caused it to be activated is our kidneys sensing lower blood pressure by little sensors they have. And we're going to look over this very famous mechanism when we get to the kidney. That's quite a bit of ways. That's multiple weeks in the future. Angiotensin does what? First thing, tenses blood vessels. Angio or blood vessels tenses it, makes them tighter. Raise your blood pressure. Makes you thirsty. Raise your blood pressure. Increases antidiuretic hormone release. That basically puts little areas in, as you'll see, in the kidney, in a particular area to reabsorb more water. Brings up. So all of these are doing kind of the same thing. They're tightening blood vessels to raise pressure. You're intaking more water. It's reclaiming more water. And then lastly, and probably the linchpin of all of this, is it generates what's called aldosterone. That, and basically it triggers the adrenal medulla. You'll remember that from endocrine. It releases the aldosterone, and the aldosterone, again, inserts little protein openings in the kidney to pull sodium, and water follows it. Once again, I had discussed it this morning with my MCAT class for the pre-med students. Stein's Mary had a little lamb rule. Where sodium goes, water is sure to follow. When we have too much water in the system, you have the reverse. Atrial natriuretic peptide. Natri, sodium, uritic, urinating it out. What happens, that extra fluid stretches those atria, which shouldn't stretch, and they release a chemical that opposes aldosterone and basically tells the kidney, get rid of the sodium. And water will be slowly following. Love that. Mary, lamb, sheep, love those. Hey. Well, so again, the baroreceptors adapt either chronic high or chronic low. They don't work long term. So other mechanisms, and this is what I told the other group. I don't want to go crazy here because we do this in kidney. Like we will review what they call the indirect. It's indirect because the direct means the kidney's doing it itself. It auto controls. As long as your mean arterial pressure is in a good range, it takes care of it. Okay. Effectively, what one of your kidney's many jobs is maintaining that appropriate level of fluid, and so helping to control your blood pressure. When we've had a lot of liquid, for whatever reason, we urinate more. What happens is that fluid increases your blood pressure. How do we get rid of the fluid? We urinate more. We void more. So basically, the kidneys get busier. So you'll see there are mechanisms in the filtration apparatus. Effectively, all the kidney is a giant filter. And there are mechanisms to increase the amount of what we call filtrate, the fluid that the kidney develops. And the more we have of that, a percentage of that gets excreted as urine. So that's what these direct mechanisms are. Hey, your blood pressure is too high. Okay, we'll have the kidney kind of take it easy, not make as much. Your pressure is too low. Okay, we'll make it, effectively the other way around. If your pressure is too high, we'll have the kidney get rid of more fluid. And if your pressure is too low, the kidney won't be as busy, so it'll retain more fluid. That's the direct, and they work. You don't have to worry about them, assuming that you don't have some primary kidney disease or anything like that. The indirect mechanism is if that doesn't do the trick, then there's a pressure and a chemical sensor down the road. You'll see this when we do the kidney that can take over at that point, and it'll eventually lead to that angiotensin and aldosterone. We'll get there. We review this. Interesting. I think we review this in respiration, and I think we review this again and really thoroughly look at that mechanism when we do renal kidney. That means if you do it that many times, it's important. Right? So here's the direct, here's the indirect. Aldosterone. I just read this to you, so I remember it. I'm good like that. I know you're all obsessed studying for Dr. Robbins, tracing that drop of blood. Why is that hard? It's pretty straightforward. It's just, I don't know. It's probably because I've lived it for 50 years. I'm not, this is not mean. It's just, I take my memory for granted sometimes. When you have something you're good at, sometimes you take it for granted. Like I would never know what it would like to be a good athlete. Okay, so I can't take that for granted. It's just like my best friend. Well, I haven't played golf for 20 years. Oh yeah, I'll go out and break 90. Why? 82, 83-year-old, 82-year-old brother-in-law can shoot his age on the golf course. It's just awful. Why? So, stuff that happens. How do we regulate blood pressure? All these things should be pretty obvious to you. I talked about the posture. You would expect your blood pressure to have to be higher just to oppose gravity when you're standing, okay? As opposed to when you're seated down, and certainly when you're lying down. And that's what we often do to test for this, what we call orthostatic or postural hypotension. We will check people, and this is one of the first physicians I work with who was an attending when I was a resident said, this is what we do. Every patient, he practiced what he preached. He'd have patients come in, he checked them sitting, he checked them standing, he checked one arm, he checked the other arm. Very thorough about that kind of stuff. Nevertheless, okay, physical exertion, self-explanatory. When you're upset about something, your pressure goes up. I mean, believe me, Friday you're going to come here, take the test. If you could continuously measure your blood pressure, it would be elevated. Normally not the bottom number. Typically the top number is what goes up when you're anxious. The bottom number stays relatively steady. Fever, just said, that's another thing. But that's hopefully a transient increase just because you're going to need more resources to fight whatever is causing the fever. And all of these things play a role. As you're older, okay, men generally have higher blood pressure than women. If you're overweight, okay, we do see, I don't know what the racial or ethnic lines of increased blood pressure. People of color typically have greater degree of blood pressure problems than others. It's just the way it is, and there's probably a hereditary basis associated with it over time. I don't have any hard and fast rules. I'm trying to be, say it the right way so you understand. It's just one of the things as a clinician or as a nurse or as a physician's assistant, when you go and look in the back of your mind, keep thinking about those types of things. I wonder if we're dealing with what we call the silent killer, high blood pressure. And depending on who's in the room, you're not profiling. You're trying to use your knowledge base as to things that can cause problems. All of that's part of this, the magic of making a diagnosis. It's like a giant jigsaw puzzle that finally comes together. Mood can do it. Yeah, you would think that's there. All that's part of it. So it's a pretty good definition. And nowadays, we used to think, oh, if you're like my age, oh, you could have 140 over 90. Not anymore. That's hot. High is high, whether you're 25 or you're 75, 85. Doesn't matter. It's high. And it has problems that are associated with it. And it has, when they say sustained, it's something that has to be tested on a consistent basis. It fluctuates. You go in, it's a snapshot. What typically they will do, maybe have someone at home who can test it. It's better to have someone checking your blood pressure than you using one of those machines to test it. Okay. And writing it down. Clinics will have patients come in every week or every X number of days for blood pressure check, typically the same time of day. Just the same way if you're on a weight loss or a weight gain program, you should check your weight at a specific interval at the same time during the day. Most people will tell you first thing in the morning. Once you get into that, that's the way to do that. And even years ago when, like Weight Watchers, which was a really good program, I mean, they would come in and just do weekly weights. That was it. Same time of day. Tell you to wear the same kind of clothing. If it was taking off your outer garments, etc., like that. Not like me when I go to the doctor. Wallet comes out, the phone's out of the pocket, the belt. Did I tell you that? Like that. I'm willing to go on my birthdays. Not now. I'd be happy. It's like now I would 40 pounds less than that. It's okay. Yeah, tell me about it. So that's the thing. Okay. It's there. And if you have a risk factor, the wonderful thing about high blood pressure, it's basically controllable. Okay. This is the problem. Your heart has to work harder. Those blood vessels we talked about with the intrinsic clotting system, like wear and tear. They're like Pennsylvania roads. They're filled with potholes if in high blood pressure because you constantly have to repair them. Those potholes can become irregular and lead to turbulence and lead to clots. You're making your kidney so important work extra hard. You're damaging the filters. It's all about filtration, and that's the major cause of kidney failure. It's to do with irregularities in that filtering mechanism, mostly from diabetes, but high blood pressure probably second on the list. And yeah, it can lead to strokes and all of those things. Overworking the heart. Eventually, the heart can't supply itself. And we call that primary hypertension. We don't know the cause. We just know the risk factors. Is it genetic? Is it, as a lot of people, is it dietary? Is it smoking? Is it overweight? We have a massive problem with weight. Hello, that's me. Hello, pot. This is kettle. Okay. Age, you can't do anything about. Diabetes, you can treat. Stress depends. It's hard. We all have stressors. I don't know. Do the best or find ways to deal with them. Whether people exercise, people relax in different ways, whatever they do. Okay? And so all it is control. Whether it's diet, exercise, taking care of the habitual factors. Medications are better than they used to be. They have less side effects. They're not side effect free. This is when there's an underlying cause. There's some primary disease of the kidney. There's a blockage in the arteries. Maybe there's a tumor. Not wishing it on people. Maybe it's some underlying disorder, whether it's in the thyroid or in the adrenal glands. Any of those are possible. And so, and then it becomes a question of, and that's typically what the workup involves. Since 90% of the time, it is an underlying cause, you treat it, and you still continue to look for the underlying cause. And again, that's where family history and things like that come into play. So I wasn't surprised, my dad had high blood pressure. Wasn't surprised to have that. Low is not bad. I mean, if you most people would sign up for low blood pressure. If it's unusually low, and the only way if there was it was symptomatic low blood pressure. If it's asymptomatic, then that's good. And if anything, you live longer, which is. And this is what I was telling you about postural or orthostatic. Ortho means straight. Static means in one. Static means to stay in one place or one position for a long time. And so, and effectively, the implication is changing position, and it's characterized by dizziness. The compensatory mechanisms are not there. And anybody on blood pressure medicine can get it. It's worse when you're older. And so, and it can be chronic, low. Again, if it's symptomatic, okay, things like that. And acute is really bad because then we're dealing with shock. And a lot of the rest is to describe what shock is. Acute hypotension means all of a sudden your blood pressure collapses. You will see folks like this. Most of the time, they may have felt ill. I just didn't feel right today. And all of a sudden, you see them, and maybe they're in a clinic, maybe they're a patient of yours, maybe somebody you know, and sit down, and it's like you can make the diagnosis because all of a sudden they go, I just don't feel right. I got to lie down. And you go over to check their pulse, and their skin is cold and clammy, and their pulse is racing. All of a sudden, I don't know what it is. That's shock. Shock means your circulatory system is in the process of collapsing. The first sign is blood is not getting to vital structures like the aforementioned brain, heart, kidneys. Your body goes into full-blown compensatory mode. So it starts racing, hence the increased pulse. The cold and clammy comes from all this redistribution of circulation, okay, and the fact that it's low, and then you're trying to compensate. You have to breathe more rapidly for oxygen. So when we see racing pulses, extra pressure breathing, or even diminished breathing sometimes as it goes prolonged, but that cold and clammy and accelerated pulse rate is a big player. They might have felt lousy because they didn't know it, because it didn't manifest itself as massive chest pain, that they were having maybe a heart attack or maybe an incipient stroke. So this is circulatory. I mean, we could make a case that it's all circulatory shock in the sense that the flow itself. I mean, it's not all the time. There are conditions in shock that affect the circulatory system. To some extent, they all do, but it's the underlying reason. For instance, in my micro group, we talked about gram-negative shock, where gram-negative gets in all those nasty endotoxins everybody should know about. It takes micro. Okay, that's a shock that's not necessarily stated here, but it's like a special subset of circulatory shock that's there. For some reason, there's some underlying cause. Hypovolemic blood loss, and typically they're implying rapid. It isn't necessarily have to be bleeding from a terrible accident. Externally, it could be internal. One of the things we do, the body's filled with hollow organs that when they're filled up typically with blood, if you have blunt trauma like that, they burst. It's like a balloon that's full. It's like a water balloon. Boom. Effectively, and it'll burst on the inside, and so you can get it from that. Vascular, okay, maybe, and again, typically it'll be an underlying cause if you want to define it. When you hear about somebody with anaphylactic shock, horrible allergy, it does two things. It releases the allergic phenomenon, releases an onslaught of chemicals. The chemicals dilate blood vessels. That's where the shock is. The blood's not getting where it's supposed to be. And then, worse yet, the same chemicals cause spasm. We call it bronchospasm. So the tiny airways deep inside your lungs close off. And you only got you have minutes, not hours, to do something about it. And almost everybody knows somebody who has an EpiPen in their pocket for some reason. Bee stings, nut oils, severe allergies, etc. And this is what I was telling you about with the heart. So all of those, the end product is the same. We just classify them differently. And I don't think I'm going to sit there and give you a scenario question. Go, this happened. What do you classify? I think I want you to just know that shock means that you're not generating enough circulation to vital structures more than anything else. And typically it's characterized by initially by rapid pulse rate. And then eventually everything goes wrong. And then and all of a sudden you get somebody, you're going to lose somebody. That's me. As I said to the other class, if you're in a clinical setting, even if you're at home and this happens to somebody, the most important thing you can do is very hard to treat those. Because most people in a medical facility, you have IVs and things you can start treating. First thing, ask for help. If you're by yourself, I mean, sit there and holler 911, whatever. If you're going to need help to deal with it. Never, even in a hospital, never ashamed to ask for help. Help is a good thing. It's one of the things is people say, why didn't you holler and ask for help? Because our normal instinct is to start doing stuff. And sometimes for all of us, even somebody who's seen a lot of those, panic. There'll be that moment of hesitation. It's not easy to do. So there's just, these are just little things, because I've experienced it. It's like all of a sudden, and it's to anybody, as you're more experienced, it's less likely to happen, but it still can happen. So there's some interesting slides on this. So this is what it's all about. Adequacy in blood flow to the appropriate area. The fancy name is right there in front of you. Perfusion. Great name. Great word. Okay. Delivery of oxygen, nutrients, getting rid of the bad stuff, gas exchange in the lungs, absorbing urine. It's got to be precise. You're going to see how it's distributed shortly. Yes, there's controls. The principal control is of the diameter, and it's all about the blood vessels, is the sympathetic nervous system. The parasympathetic has nothing to do with the smooth muscle of the blood vessels. That's why it's all about, when it comes to the kidney, it's all about the sympathetic nervous. Remember we did autonomic nervous system. There's certain things that the sympathetic has, the parasympathetic does not. This is one of those areas. So we're looking at blood flow specifically, kidney function specifically, okay? So they act on the smooth muscle and those tiny vessels. That's how they control blood pressure. The resting tone, once again, of the sympathetic nervous system is the lower number, your diastolic. And it's just adjusted. If there's an increase in that area, if you ate something, there's stretch and chemical receptors, it's going to send blood flow into your gut. Okay, if you've had a lot to eat, a lot to drink, you're going to have more fluid that's going to go to your kidneys. You're going to have auto-regulation. That's how those systems work. You should not have to worry about that type of thing normally. When they use the term intrinsic, it means it's in there. Just like kidney, by and large, auto-regulates itself. Extrinsic means something else has been involved. Is it nerve supply from the brain? Is it hormones from the pituitary, the thyroid, whatever, the adrenal glands? Okay. The intrinsic controls typically stretch and chemical receptors. And when you see the term paracrines, they are chemicals that are released and work locally. They don't travel. It's not like endocrines. They're sort of they're a distant cousin to the endocrine system, might be a way. And we look at those a little more closely in immune, because that's how the immune system works. It tends to work. We have local mechanisms to generate really what the immune system does best, which is called inflammation. So this is what happens. At rest, our skeletal muscles receive 20%. Okay. During exercise, normal exercise, they could receive over 70%, even more sometimes, it seems like. So what happens, we see that, and fight or flight mimics it. The skeletal muscle arterioles dilate, and at the same time, that's intrinsic. Same happens to the heart. Extrinsically, other organs such as the kidneys and digestive don't need it. When you're vigorously exercising, it is the reason why you don't have to run to the bathroom is because there's minimum amount of blood flow. So the mean arterial pressure is still maintained because of blood flow elsewhere. So I love the illustration, one of my favorites in this textbook. The brain is the brain. You always get from the brain, same thing. It doesn't matter whether you're upside down, right side up, active or not, the brain gets the same. I mean, if you're prolonged upside down, it would overload sensors and there would be a problem, obviously. Triple the heart. Look what you can do when you triple blood flow during very vigorous physical activity. You can increase factor 10 times. So here, you're going from 5,800 average, 5.5, not quite 6 liters per minute, to nearly 8, tripling that, 17.5 liters per minute in this vigorous scenario. You can generate by tripling it to the heart, we can magnify, and again, this is training and exercise and fitness levels, this massive level. We have to send some of it to the skin, literally just for cooling. We're generating so much temperature that isn't perspiration in and of itself is insufficient. We have to redirect blood flow almost to let the heat radiate off. That type of thing. But the big player here, what makes it all possible, is we're not proportionally, we're not having 33 and 4,200, a total of 7,500 milliliters going to these areas. Oh no. I mean, very little, trace enough to keep them viable, because sooner or later you're going to stop that vigorous physical activity, and then your body has to catch up with all the stuff. It has to get rid of all the waste products you generated, has to redistribute the circulation. You're going to eat, you're going to rehydrate, it's got to be able to deal with those things, etc. So a lot of that. Reactive hyperemia, I was explaining to the other group, it has a lot to do with, it's kind of like, and we'll learn about it in repro. It's almost, it's basically why menstruation occurs the way it does, why we release a tourniquet, we do so slowly, because it builds up a pressure head. That's what's meant by reactive hyperemia. If you obstruct blood flow from an area, and even if you release the tourniquet slowly, that area will go from very, very pale, because there's no blood supply, or minimum, and to look disproportionately reddened. That's because it's got an overabundance of blood flow. What happens during menstruation is the spiral arteries, because of a lack of progesterone in the absence of implantation, spasm. The spasm separates the layer of the endometrium. When the spasm is released, that reactive blood flow not only separates the layers, but causes the outer layer to slough. So you lose the endometrial layer, called the stratum functionalis, and at the same time, you lose a certain amount of blood. So there's lots of different mechanisms that play a role in that. So, and these are just common sense things. So you're using up oxygen, you're building up waste products. We talked about that in muscle physiology. We have certain kinds of local chemicals that play a role. Okay, when there's too much stretch on blood vessels, they release nitric oxide, a big player that we're only really learning about by the lining cells. The lining cells aren't done. The lining cells, when they can also do vasoconstriction, they balance each other out. Nitric oxide and these what are called endothelins keep balance, unless blood flow is inadequate, in which case nitric oxide wins. Okay. And again, there are local chemicals from inflammation that can override or accentuate this problem. So it's very interesting. There's a lot of controls. Again, when we classify those, these are different kinds of metabolic controls that are there. Different changes in the smooth muscle. And basically, they're stretch receptors. Okay. If the vessel is stretched more, it will respond reflexly. So it'll make sure there isn't an overabundance of flow going in there. If it's not stretched enough, it'll relax, and that'll allow more flow. So these are really very, well, I always describe it, elegant controls that just these are things you don't have to notice. They're just happening to you and keeping it that wonderful degree of homeostasis. Okay. And so long term, this is it's why if you're in cardio rehab or if you're what I'm doing now, really focusing on cardio like 4 to 5 days a week, you're building up collateral channels. You're doing it by design. If somebody's in rehab, they've had some kind of event, maybe a procedure that's done, and you're trying to build them up therapeutically so it doesn't happen again or something tragic happens. If you're like me, you're in prevention mode. Call that scary. About something bad happening. About time. It only took me 70 to do that. So these and altitude, you kind of your body kind of does the same thing to compensate for the thick blood. And initially, you don't have the oxygen carrying capability. And they summarize these quite a little bit that are there. And I think we'll stop it here because it's kind of where I stopped with the other group about how we kind of maintain it. And we'll hopefully conclude the chapter on Wednesday.